Namaskar and a very warm welcome to today's webinar. So today the topic is scoring systems, validity and use in the ICU. So this was supposed to be done on Sunday, but there was an emergency and we had to kind of postpone it. So it's a very different kind of webinar in the sense this is never discussed in webinar scoring systems, but it was requested for by one of our colleagues, and we're going to have this today. So the speaker is Dr. H.R. Rajathadri. So Dr. Rajathadri is a young, bright intensivist. He's done his MD anesthesia and DM critical care from All India Institute of Medical Sciences in New Delhi, and he was the topper for the DM critical care entrance exam during his time. And now he's assistant professor in the Department of Critical Care Medicine at Ramaiah Medical College, Bangalore. So we'll keep the questions that you may have in the end. We'll take the questions in the end. Okay, then Dr. Rajat, let us start.
Sure, sir. Can you see the screen, sir?
Yes, yes, yes.
Yeah, okay. So let's straight away dive into the topic. So this will be the outline of my talk, where I will start with classification, and then we'll see what are all the severity scoring systems, organ dysfunction scores, which is the best among all, and why do we need the scoring system, and what's new in the scoring system. This will be the major outline of the talk. So jumping straight into the classification. So there can be organ specific or disease specific score like GCS or Ranson score or ICH score, or there can be a generic score or a severity score. Among the generic scores, we have disease severity score or organ dysfunction score. We will be more focusing on what are the disease severity score, what are the organ dysfunction scores in this topic, rather than jumping into the organ or disease specific score. So let us first understand what are the severity scoring systems available, which are these scores and how are these scores made. So I will be more focused on what are all the common scores available. There are many scores available, but what are all the common scores which we use and why do we need it and what are its limitations and everything. So the scoring systems are built by various methods. We will understand over the course of the discussion that what are all the methods to predict outcomes such as mortality. All the scoring systems, all the severity scoring systems have one thing in common, that all aspire to predict mortality accurately. But some also predict other major outcomes such as length of stay also, like Apache 4 can predict length of ICU stay. They are built on prospectively collected data, and each score has a particular time frame from which the data is collected. This needs to be followed. Suppose Apache 2 has a time frame of 24 hours from the ICU admission, but coming to SAPS 2, it has a time frame of 1 hour into the ICU admission, something like this. So it has to be followed. We cannot invalidate this rule. So there are certain things which we need to understand before jumping into the scoring system. So there are certain terminologies which we have to understand. So validation. What is validation? Validation of the scoring system is the process of evaluating the accuracy of the scores. Suppose validation means, so we want to get validated by our professors. We want to get validated by our patients' relatives saying we have done a good job, something like that. So there can be a score made by a certain group that has to be validated by a different group in a different set of population, saying, yeah, you have done a good job. The scoring system is accurate in predicting whatever it has to predict. So if validation fails, suppose the US people build the Apache score and Europeans want to validate it. So they did a study and validation fails. It's not accurate in their population. So what can we do then? So we can do something known as customization. Customization can be done at an institutional level, regional level, or national level based on the data of their own patients. Each group of patients can be different. So suppose, for example, I used to work in AIMS New Delhi. The average age of admission into the ICU was lower. The average sickness of admission into the ICU was higher. But in a corporate hospital where I work currently, the average age of admission is higher. The sickness is lower. Many soft cases get admitted. So the scoring system will not be particularly helpful in two different aspects of this population. So we have to customize at an institutional level, regional level, or national level, depending on the level of ICU, depending on what the care of ICU we are giving, and if the scoring systems work or not. So some of the key characteristics of scoring systems is the discrimination, the accuracy of given prediction, its ability to discriminate between survivors and non-survivors. So it is measured as AUROC, area under the receiver operating characteristics. Higher the AUROC, better is the discrimination. So what is calibration? The agreement between observed and predicted mortality rates across different probabilities of the death. So in the sense, what does it mean? Suppose the Apache score is 10, the mortality will be around 15%. And if the Apache score is around 20, the mortality will touch up to 40%. So even at a lower Apache score and higher Apache score, the predicted mortality should be accurate. Then only we call it it is a calibrated system. So if it is only performing better at a higher scores or a lower scores, then it is not a calibrated system. Then we'll have to calibrate it accordingly. So calibration weakens over time for different characteristics. Suppose pre-proning era in ARDS, the mortality may be higher. But for the same set of variables, if you calculate mortality now, post-proning, the mortality will come down. The mortality has come down because of change in population, change in advancement in medicine, and all those things. So we have to recalibrate the scores over time to have the same prediction, same the accuracy level, same discrimination. So coming to the timeline. So majorly we will be talking about Apache score, SAPS score, and mortality prediction model, that is MPM score. So first came the Apache in 1981, then SAPS in 1984, and MPM in 1985. Then subsequently Apache 2, Apache 3, Apache 4, SAPS 2, SAPS 3. So we'll go according to the timeline itself. So Apache, this is the paper by William Noss in 1981, published in Critical Care Medicine. So we have to understand why he made this scoring system in 1981. So he says the Apache system is not designed to assist in making individual treatment decisions. Very important to understand that it is not designed to assist in making individual treatment decisions. Suppose the Apache score is 100 and the mortality reaches up to 85%. Does not mean we have to consider that the mortality is 85% and it is futile to give any treatment. It is not the purpose. Its purpose is to rather classify groups of patients on the basis of severity of illness. So this is the most important thing. So two components, the primary Apache has two components, acute physiology and chronic health part. So if we see Apache, there are four variations, Apache 1 to Apache 4. And all the Apache uses worst values of the parameters which they have chosen within 24 hours of admission to the ICU. So these are the characteristics of Apache. If you see, so how did they select the variables? A panel of experts, the authors of the paper, sat together and decided these are going to be the variables which the Apache score will consist of. And how many variables did they decide on? 32 variables. This is very important. So they've excluded patients with less than 16 years and the time of data collection first 24 hours. Very important. So if we see, the sensitivity was 97%, positive predictive value of 90% for this paper. Then in 1985 came the Apache 2. So the same authors, William A. Noss was the first author of this paper. So we have to understand why he made up the second scoring system. So he says the Apache has proved useful in evaluating the outcomes and comparing the success of different treatment programs. However, original Apache system is complex, has 32 variables. Now needed a multi-institutional validation. It was only done in 2 institutions previously. So the Apache 2 was done to simplify and make it statistically more accurate and valid in patient classification system. This is the aim of creating this score. So if we see, so here we can see number of ICUs 2 and number of ICUs increased to 13 here. Number of patients 705 and here 5,800. But selection of variables still was dependent on the panel of experts itself. Here they decided to exclude burns and post-CABG patients and cardiac surgery patients. Pretty good AUROC, 0.85. So this is the thing, but the other thing which they added in Apache 2 was the age of the patient. So the Apache 2 score is a sum of Apache score, age, and chronic health Chronic health, they've classified into if non-operative or emergency post-operative 5 points, for reactive post-operative point, it is 2 points. Based on the addition of these three components, the total Apache to score was calculated. So then came in 1993 Apache 3, then in 2006 Apache 4, huge number of patients, but the major important change was the use of multiple logistic regression. A statistical method was used to give the variables. And second thing, if you see here, it is 26 variables, still okay, but Apache 4, 142 variables, very data intensive, very data intensive, very difficult to calculate the Apache 4. And Apache 3, the limitation was that it has a proprietary algorithm to give the probability of mortality. So it is not publicly available. So that's why the use of this score is very less. But the use of Apache 4 is also very less for different reason. The number of variables is 142, very cumbersome for any person to do. If we take Apache to only 17 variables, we can do very easily. We can ask the nursing staff in our ICU to calculate the score, and it's very easy. So then came in 1984. If you see 1981 Apache and 1984 by the European team simplified acute physiology. Why did they do even though Apache was there? So the Apache is to facilitate multicenter studies, reliable outcome comparisons in patient groups of similar pathology. Although Apache APS is generally accepted as a reliable estimate, the estimate of severity of illness in individual patients, variations in the mean number of data collected per patient may introduce systemic bias in patient scoring because missing values are interpreted as normal. With what that does it mean? It means suppose we have creatinine in our scoring system and we have not done creatinine in the first 24 hours, or we have not done an ABG in the first 24. Still possible in low research settings. So in first 24 hours, if we have not done, we don't add into the scoring system, it is considered normal. It will give falsely low value. So what they did, they have taken few variables which are commonly done in the ICU, and based on that, they have tried to make the scoring system. So basically a simplified Apache taking the worst values within 24 hours, three versions available, SAPS 1, 2, 3. So main advantage, data extraction easier compared to Apache, and data derived from many countries unlike Apache. But although we have to take this with a pinch of salt, data derived from many countries, all the countries were European countries initially. The European countries more or less have the same kind of healthcare system, same kind of patient admission and everything. Although they say it is validated in different countries, it's like a homogeneous population, even though it is divided geographically into different countries. Good discriminatory ability compared to Apache. It's not like the Apache has very high AUROC and SAPS has very low. These are some of the parameters which they took in SAPS 2. So then came the mortality prediction model. The mortality prediction model, why did they do? The present paper reports the result of method for estimating hospital mortality of ICU patients based on multiple logistic regression model. All these while people were taking the expert panel and then deciding which parameters to use. But this in 1985, they decided to forego that and bring a multiple logistic regression model to know which variables to use. So they determined a statistical technique known as maximum likelihood rather than a team of experts, and the result is expressed as probability rather than a score. So they're giving the probability of mortality. So the author of this paper is Stanley Limsau. So we have to give credit to this author because he was the one who devised how we can calibrate the scoring systems, how we can measure the calibration. It is based on his method. So three versions available, except age, all the variables are dichotomous. Dichotomous in the sense whether it is there, whether it is not there, yes or no. So only clinical data, no laboratory data. So lowest extraction burden. So if you see the scoring system here, see medical or unscheduled surgical admission, yes, no. All the things are yes, no, except age. Coming to AOROC, more or less everything is same, but maybe MPM3 is lesser, but none have been proven one is superior over the other. So everything comes with its own limitations. So what are the limitations of the scoring system? So as we have already known that cannot be used to modify care for individual patient. We cannot say this Apache score is high, I will not treat this, or Apache score is low, does not require ICU admission, something like that. Okay. The lead time bias, variations in pre-ICU care. Suppose there are two hospitals. One hospital is having excellent emergency room. The other hospital is not having good emergency room. So excellent emergency room will stabilize patients thoroughly, evaluate, keep them for some time, and then shift to ICU. So in those set of patients, the severity score will be lower. In the patients who have not stabilized properly in the ER and shifted directly to ICU because of logistic issues or whatever issues it is, the severity score will be higher in those patients. This can lead to bias, lead time bias. Some conditions with high scores but low mortality, like post-surgical patient coming to with a very high lactate, tachycardia of 160 because of hypovolemic shock. But if you correct the hypovolemic shock, patient becomes absolutely fine. To suppose DKA, you give insulin, you give potassium, you give fluids, patient becomes absolutely fine. So even though scores are high, mortality will be low in such patients. Missing variables are considered normal. We have already discussed this. So suppose if we don't measure those variables, it is considered normal, will lead to lower score, and this leads to a bias. And the score is not on a linear scale. Suppose there are two patients, Apache 10, Apache 20. The mortality is not twice for a patient with Apache 20 compared to 10. It is on a logarithmic scale. So this is about severity scoring systems. Now let us jump to organ dysfunction scores. So these are the scores designed to assess severity of organ dysfunction. So we take each individual organ system and we score accordingly how badly they have been injured. Higher score indicates higher mortality, but they were not designed for the purpose of predicting mortality. But although higher scores indicate higher mortality. So it is also, unlike severity scoring system done at a single point, it is scored daily to look for disease progression and response to intervention. So first score which came was in 1994, although this paper got published in 1996. 1994 SOFA score was made. Then the team by J.L. Vincent modified the SOFA to bring us the SOFA which we are using currently. So originally originally designed to describe sequence of complications or organ dysfunction, but inevitably it correlates with mortality. So we already discussed this. So used to diagnose sepsis. So before sepsis 3 came, sepsis was not diagnosed based on the organ dysfunction or increase in SOFA score, not predominantly used in ICUs also. The SOFA score became much more famous, extremely famous after the introduction of sepsis 3, where increase of SOFA score by 2 is used to diagnose sepsis. So this is the famous SOFA score which we are using, which every one of us know. What are the limitations of SOFA score? Various limitations. Done in 1996, no modification. So measurement of GCS in an intubated patient becomes difficult. Use of dopamine, dobutamine as first-line vasoactive agents. So we don't use it. Noradrenaline will be the first choice. So vasopressin will be a second choice. So it is based on same dosages. Use of creatine for calculation of SOFA. Suppose patient is undergoing RRT. That means he has very severe kidney dysfunction, stage 3 of AKI. But although when we do a renal replacement therapy, creatine comes down. If we use the same creatine value, it is pointless because patient will have lower creatinine, but will give us a falsely low SOFA score. Difficulty in measuring PF ratio in low income countries. Some African countries might not have ABG facility where you difficult to measure PF ratio and everything. So then came Q SOFA. Although digressing from the topic, let us understand what is Q SOFA. Three components. If the two components are present in a patient with infection, then a higher risk of poor outcome. Three components were systolic blood pressure, altered mental status, and respiratory rate. So initially thought that we can use this for screening of patients for requiring admission, but validation studies did not prove it to be very useful. That's why it is not anymore recommended to use as screen for sepsis. So because of limitations of original SOFA came a lot of modifications. So we can see two modifications here. So modified SOFA where GCS is not there at all. The rest of the things are there. Then another modification where coagulation parameter has been removed. So rest of the things are there, but some modification like SF ratio are used. Instead of bilirubin levels, scleral icterus or presence of jaundice is used for hepatic. So cardiovascular and neurological were same. So these were some of the modifications. Then came cardiovascular modification SOFA where different parameters were added for cardiovascular system. Extrarenal SOFA where they omitted the creatinine levels itself. Then CLIP SOFA for liver failure patients. Then subsequently came further modifications, Q SOFA, SOFA in hematological malignancy patients, SOFA with RAS, then pediatric SOFA patients. So many modifications. But none of them are in clinical use. None of them became famous. Why? They originate from single centers with specific set of patients. Did not get validated in large multi-center studies. Some have reduced parameters, like suppose modified SOFA has stopped measuring bilirubin. Suppose patient has icterus, no icterus, it becomes dichotomous. One patient can have bilirubin of 10, icterus is present, bilirubin of 5, icterus is present, does not indicate the same severity. So this reduced laboratory-based parameters lead to some inaccuracies. That is why it is not so useful. And again, clinical examination, which can be subjective. Some can have muddy conjunctiva, can have, we might think the patient has jaundice, but clearly patient's bilirubin may be 1 or 0.5 where there is no jaundice. So in such scenarios, again, it becomes inaccurate. What are the other organ dysfunction scores? Logistic organ dysfunction score, same purpose as SOFA, more or less same parameters of SOFA, but more same organ systems, but increased parameters. Multiple organ dysfunction score, similar to SOFA and LOTS, gives mortality prediction along with organ dysfunction. So more or less came at the same time period, 1996, 95, 96. So if you see logistic organ dysfunction, some different parameters are added: creatinine, urine output, heart rate, SBP, and all those things. Then in multiple organ dysfunction score, pressure adjusted heart rate is there. So more or less same thing. So this is about organ dysfunction score. Now we'll understand which one is the best scoring system available for us, which one to use day in, day out. So if you ask anyone, there is no single instrument which has convincing or proven superiority to other. We already discussed more or less AUROC is same, half of the parameters are same. So what we should do, we should see which score is best for us, validated in our population. So the score which is validated in European or American population may not be accurate for Indian population. So we have to develop our own score, validate in our population. That is ideal for us. Then also consider feasibility, ease of use, and cost. So feasibility, ease of use will not be obviously good for Apache 4, 126 parameters. It's difficult to chart all those things and keep a track and all those things. And cost, we can't use proprietary algorithms. It adds to the cost of care. Already the cost burden is very high in the ICU. We cannot add more. So if you ask me which is the best scoring system, no best scoring system. So original Apache, SAPS, and NPM only historical significance. Apache 2 most widely used and quoted in USA. SAPS 2 commonly used in Europe. Apache 3 not in public domain because of the proprietary algorithm. SAPS 3, Apache 4 better design but more data intensive. So not used. NPM mod slots uncommonly used. So why do we need scoring system? This is the most important part of the topic. So we know there are a lot of scoring systems. We don't know which is the best one. We can use any of the scoring systems. So when we cannot decide the level of care or whatever care the patient needs clinically, so what is the use for us? If there is no use clinically, then why are we doing all this? So scoring systems have very important role in RCTs. So suppose in a randomized controls trial, we have to assess the balance between two groups. There are two groups. One is receiving placebo, one is receiving treatment. So the group with treatment cannot have a lower severity score. It has to be balanced between the average Apache score between the two groups should be balanced. There should not be any difference between the two groups. If there is difference, then there is obvious bias and the results cannot be interpreted. They cannot be taken for their face value. In observational studies also to identify potentially causal effects of treatments. So unlike RCTs, they cannot give us exactly whether there is causality or not. They can only correlate the effect and cause. So we have to use these scoring systems for matching. So matching in the sense, so we are doing some case control study where we have to match the cases and controls. The cases cannot have higher severity score, or controls cannot have lower severity score, something like that. You have to match, and you can do it by various methods or propensity scoring, something like that. Okay, then used in RCTs, look for treatment effect with subgroups. Suppose like we are doing an RCT of steroids in ARDS. So we can classify the patients based on the severity. The higher this, let's take a better example. Suppose sepsis. Sepsis with higher severity score has better propensity for for the treatment. So in such scenarios, we can use the scoring systems. Suppose we classify after the RCT, we can classify the patients in two groups: higher severity score, lower severity score. So we can see if there is any mortality benefit in those patients who had higher severity score, or if there is any mortality benefit or any benefit in lower severity scores, if the treatment is proving to be more useful in the lower group, something like that. So used as either primary secondary endpoints in RCTs. So there can be RCTs where the primary outcome will be reduction in SOFA score over time. On day compared to day one, what is the SOFA score at day 7? That can be primary or secondary endpoint in the RCTs. So scoring systems in quality control compare performance of ICUs over time within the same ICU or with other ICUs. So how can we compare? We can compare using standardized mortality ratio. What is standardized mortality ratio? The ratio observed to expected deaths. So how can we know what is the expected death? So suppose the SCOFA score of 20 has an expected death of mortality of around 40%. So at SCOFA score of 10, average SOFA score of 20, what is the observed death in our ratio in our ICU? So suppose SMR is around 1, then that means we are doing okay. If there is lower SMR, then we are doing good. We are doing better. We are giving better care. If the SMR is high, like 2, 3, 4, 5, then that means we are doing very bad job. We have to address why we are doing a bad job based on the SMR, and then we have to see. But it comes with a pinch of salt. If the scoring system not validated in a population, then we cannot use it to calculate the ICU performance. Sorry. So we can use the scoring systems again to assess the impact of change in staff ratios, bed number, other interventions on patient outcomes. So how is the SMR varying when the staff ratios are changed by adding bed numbers, or if we are doing some other intervention. Then higher admission scores indicate that there are lack of beds leading to admission of sick cases to the ward. So when I was working in AIMS Delhi also, we used to have, in our ICU, we used to get a lot of sicker cases because the bed numbers are limited. The patients coming to the ER are huge. So we had to manage a lot of moderately sick cases in the ward itself and take those patients which are very sick into the ICU. So it means it leads to this higher admission score. So we have to address those causes at an organization level or at a different level. So what do the scoring system mean in clinical practice to us? Never use it to decide the site of care, level of care, or decision for withdrawal of life support. Never use it. Serial SUFA scores can be used to as a surrogate for response to therapy. This is very, very important. So this is the only thing which we can give clinically that patient is getting better. SOFA score is reducing. So that means patient is getting better. So resource allocation based on severity. So suppose we can make a system where we have to ask the nursing supervisor to tell us to give higher the severity score. We can ask the nursing supervisor to allot 1:1 staffing. Lower the severity scores, we can ask the nursing supervisor to allot maybe a highest ratio of patients, like a 1:2, 1:3. If the patients are soft admissions, just for monitoring, some cases like that. So this is about resource allocation. This is the summary. They're used in clinical research. They're used at a society level for communication between clinicians and patient families. Policymakers and governments can use it, and ICU managers and staff can use it. Healthcare managers and funding sources can use it. So based on the ICU scoring systems. So what's new in our scoring system? So all this while we were talking about snapshot scoring system. So this can misclassify patients due to exclusion of relevant risk factors in the score, complications arising during the ICU treatment course, or treatment effects that modify the outcome. So what we can do, we can dynamically assess the scoring system, which were later developed, which have better discriminatory ability than the traditional scoring. These have not become very common in the ICUs, but yeah, they're there. Then there comes a role of artificial intelligence and machine learning based scoring system. Many algorithms are available. We have to understand logistic regression is one of the methods of machine learning, but not the only method. There are various methods like SVM, there are methods like classification trees, there are methods like neural networks and all those things. So one such example is super ICU learner algorithm. So what are the limitations? So they are data intensive. The missing data leads to a lot of bias. Data intensive things cannot be done manually by any nursing staff or any clinician at the bedside. So as and when the data is entered into the electronic health record, they are taken by the algorithms, and they give the probability of mortality in such patients. So algorithms are as good as the data. So suppose the data is recorded on a monitor. We have stopped putting the pulse ox, or pulse ox is missing, and patient has removed the pulse ox or something like that. In such patients, if you record pulse SpO2 values on the monitor, it may be not recorded. Such scenarios, it leads to bias. So the algorithms are as good as the data. If we are giving the best of the best data, they give us the best outcomes. Of course, missing data leads to bias. We have already discussed this. And patients which have maximum data are always the sickest. And this is the, again, bias. So suppose I have a simple postoperative patient in the ICU. I do not do an ABG. I do not have pH. The pH is used in the algorithm. So I don't have the data of those patients. So deployment of these tools are also very cumbersome. We need an algorithm. We need continuous computer algorithms to continuously monitor the data and then take it into the algorithm and give us the probability. So that's why they have not come into the main practice yet. Maybe in the future they will come. So till now, what we have learned, we have used so many data, physiological variables, patient characteristics, organ failure, premorbid health status, quality of life. Maybe there are few scoring systems which have used genetics, epigenetics, biomarkers to give us a lot of things like help us in audit, ICU performance, resource allocation, clinical trials, interventions, quality assurance. But what we have not taken into consideration in these scoring systems, very very important in our clinical practice, is patients or family wishes. We don't have it. Clinicians experience, we don't have it in the scoring system. That can alter if clinicians experience is more, can have better outcome, or capacity or restraints of the department, it is not included. Low resource settings can have mortality, higher mortality, but higher resource intensive settings can have low mortality. And differences in organizational infrastructures, like there are two hospitals, one with good ER, one with bad ER. So all those things come into play, but these are all not included in the scoring system. So scoring system comes with its own bias of all those things. So we have to keep in mind clinically about the scoring systems and their application. So take home message, scoring systems most important for audits, research and quality control. Which ones to use? Ideally develop an in-house scoring system depending on the feasibility, depending on the cost and ease of use. You choose whichever scoring system is feasible. Clinical care, never used to make any clinical decision based on the scoring system. And most important thing in our ICUs is always consider patients or families wishes, risk or cost benefit ratio into treatment, and not the score itself. When it comes to the treatment, the humane side of the ICU part should be considered into the clinical decision rather than the scoring system. But we have to use scoring system wisely for improving our ICU care by continuously doing audits, research, and quality control in our own ICU. Thank you. If there are any questions, I'm happy to take.
So, Dr. Rajat, can you just stop the share screen? Okay, very nice.
Yes.
Thank you, Dr. Rajat. Very nice, and you explained the use of scoring systems. So, of course, there are various scoring systems. He has named a few, but There are scoring systems which are specific to disease, such as the MELD score, Child-Pugh score, and you just told about the coma, the GCS, the 4 score. So there are scoring systems which are specific to certain systems. Also, Cliff SOFA score again for the ACLF. So those are there, but generally Apache, he has told you about Apache 2, which is commonly used, which predicts mortality at admission. And we should all be knowing the SOFA score. The SOFA score is very important because it not only is a predictor of mortality and prognosis at the outset, but also is a dynamic score. In the sense, you can do it every day and it predicts what is happening to the patient. And you can use it to kind of guide you also, and it helps in talking to the patient's family also. The SOFA score is very important, and that is one score we should be doing, and you should have some idea of the interpretation. For example, at a SOFA score around 10, I think mortality is 50%, and after that, at a SOFA score of 15, the mortality is 90%, right? So some idea should be there about the score and the mortality correlation. So that is, I think, about all. There are no questions, but definitely scoring systems objectivize things and the prognosis, and they have their own use. But they cannot be used blindly also, because he has shown you the limitations. All scoring systems have their limitations also. So I think I don't have anything more to say, and there are no more questions also. So thank you, Dr. Rajat. Wonderful listening to you, and really apologies to you and to the audience for canceling or postponing it last Sunday. There was an emergency, so it had to be postponed. So I think we shall close it, Dr. Rajat. There are no more questions. Huh? Thank you so much.
Yeah. Thank you, sir. Thank you for the opportunity. It was nice talking to this forum.
I thank the audience for their patient hearing. So we'll put it up on our YouTube channel in a couple of days. Thank you, everybody. Good night.
Right. Thank you.